Hello everyone, my name is Sarah Bourne, I'm one of your radiography tutors. My colleague Carly Dofo, Mark Viner, we are going to be teaching you dental radiography over the next few years, and so we'd just like to introduce ourselves. I prefer to be called Sarah when you're talking to me. If you feel uncomfortable with that, then please refer to me as Ms. Bourne. Now at this point we will get you to introduce yourselves, but of course you're not here. But we would in fact at the same time as you introducing yourselves go through a few ground rules. Carleen here will go through those ground rules with you.
Thank you, Sarah. So as Sarah has mentioned, this seminar is a recap of the 3 lectures that you had and the one that talks about EMA and the regulation that governs the use of ionizing radiation. We're going to make this seminar very interactive. There are questions embedded in the seminar, and I would advise that when a question is posed, please pause the video and try and see if you can synthesize the question for yourself. In that way, you get the most benefit from this session. Also, I introduced this book to you during the lecture. That was an old version, but this is Essentials of Dental Radiography and Radiology, 5th edition. We're going to discuss parts 1 and 2. You can access this book from the library or the e-library. During your clinical session, there are some things that we'd expect from you. One is that we'd expect you to arrive on time. If for any reason you're going to be late, please let us know, send us an email. We do understand that there are some unforeseen occurrences that will prevent you from coming for your session, but please let us know in advance. Also, there are instances where your sessions might clash with other programs that you have and you'd want to swap the session with other colleagues. Even if you do this, please send us an email so that we are informed. Also, we want you to come with nicely ironed tunic, neatly dressed, looking professional. You have to be bare below the elbow. Also, please make sure that you tie your hair nicely at the back. No nail varnishes or long nails because they damage the phosphor plate and the film as well. And the most important is remember your interpersonal skills. So treat everybody like you'd want to be treated. So the tutors, your colleagues, the receptionist staff that you see on your way in, the radiographers, patients and carers, everybody treat them as you would expect to be treated. Oh, and one last thing I forgot. Remember that no phones are allowed during any clinical session, so no texting or making calls. We do understand that there are times that you need to make an urgent call, but please let us know. We don't want to be seeing you on your phones chatting when the session is in progress. Thank you.
So what we're going to cover in this session is, a lot of it's going to be a bit of a revision from your lectures, but we're going to cover the legislation. We are going to talk about cross-infection. We're going to talk about the X-ray equipment, how it works. We're going to go through how to take an X-ray of intraorals today, mainly. So we will be putting the holders together. You will be using the holders plus the phosphor plates, and you will be putting them into Dexter's mouth, and then what we will be doing is looking at the images afterwards. So obviously to get from the phosphor plate to the computer, we'll be talking about processing of the phosphor of the images as well.
Excellent. So you will possibly remember that when we discussed X-rays in the lectures, I asked you a question, and that was, when were X-rays first discovered? And hopefully you have all remembered that they were discovered in 1895. Think about that. They were discovered in 1895. When would you think that they would go into clinical use? So if we made that sort of magnitude of discovery today, we're probably looking about maybe 15 years or so of testing and making sure that they were safe to use. So it will probably surprise you, if not shock you, that they were in use at this hospital a few months later in April 1896. So we've got something there that really people didn't know a huge deal about. and they started using it straight away. And one of the things that they used to do was in the morning, radiographers would test the equipment by using a test object, and they used their hand. And they would expose their hand to several minutes worth of x-rays just to see whether the equipment was working correctly. Now, thinking about that and what we know about radiation today, you're going to find that very shortly, exposing your hand for several minutes of radiation a day, you begin to get skin burns, you begin to get nasty things happen to you. And you will remember all of those effects, the stochastic and deterministic effects that you can get. Well, the very first one of those is going to be skin burns, reddening, and 4 of the early radiographers at this hospital died of their radiation injuries. So a lot was learned through the sacrifice of those people in the early days, over about 20 years worth of work with radiation. And it wasn't until the 1920s that we started to get legislation to protect us, and that was based on all of the experiences that they had. So I don't know whether you can see the screen on my left. We have LED screens here. We have the X-ray tube itself. We're going to talk a little bit more about this, but this has shielding all the way around so that the radiation only comes out in one direction. The early X-ray tubes didn't have any sort of shielding, and the staff members literally just stood quite close to them, so they didn't know what they were dealing with. So today we have a lot of things that are built into the equipment, into the design of the room, and we also have legislation, which you all know about, which we're going to go through in a moment, which protects us and protects the patients from over-irradiation and from those ill effects.
So, as Mark has mentioned, radiation is dangerous, and we have to protect ourselves, other people, and the patients. So, IRR, Ionising Radiation Regulations 2017, covers the equipment, other people, i.e. the public, and the staff. So, if you don't know what is in IRR, I suggest you look it up in the book and you revise it. Then, of course, we have IRMA, which is Ionising Radiation Regulations, Ionising Radiation Medical Exposure Regulations 2017, except that it was tweaked, and so therefore now it is 2018. So there is a little bit of controversy about whether it's 2017 or 2018, but I'm going to talk about 2018. So, IRMA covers radiation protection for the patient. Now, there are 3 basic tenets that the IRMA regulations are based on, and that is justification, limitation, and optimization. Okay? So, justification is where a request comes in for a patient to have a panoramic for query presence of AIDS. Now, that, as a request, is not properly justified because the patient is not suffering from anything, the patient is not going to have an operation, this is totally not justified. So we wouldn't do it, and we would go back to the clinician and say this is not being properly justified. If, on the other hand, the patient arrives with a request saying multiple episodes of pericoronitis, removal of wisdom teeth, position of wisdom teeth, then we would carry on and do the panoramic. Now, when we're talking about limitation, what we're trying to do, as Mark alluded to, was to reduce the doses of the patient. And we do this in a variety of ways. He talked about the only place that the radiation comes out from the X-ray tube is from here. And if you notice that on the end of this X-ray tube we have a rectangular collimator. This reduces the amount of radiation received by the patient, and it's also in the approximate shape and size of an image receptor. Also, we make sure that when we are going to take the radiation, the X-ray tube is as close as possible to the patient, because if you remember, there is something called the inverse square law, and remember also that there is a divergent X-ray beam. So the further you have the X-ray beam away from your patient, the bigger area it covers, but also due to the inverse square law, a quarter of the radiation will probably get to your patient, which means that you'll get a very pale image. The other ways that you can reduce the dose of the patient is by making sure that you use 70 kV. We use 70 kV because it reduces the skin dose by a considerable amount compared to 60 kV. It reduces the time of the radiation, exposure time, and it does have an unfortunate effect that actually it reduces the contrast of your image, but actually it is a trade-off between quality and dose. So there are lots of other ways of reducing the dose of the patient. One is make sure you've got the correct patient in your chair. Also, so you need to check date of birth, you need to check name, you should check address, but sometimes that's quite difficult to do. We also need to make sure that the patient is properly prepared, so earrings, necklaces, if you're doing extra orals, false teeth, a brace, anything inside the mouth that can be removed before that could obscure the area that you would like to look at. Now, my colleagues are standing behind the camera here, so they're going to help me out here. Any other ways of reducing the dose of the patient, you two?
Patient positioning.
Well done. So make sure that your patient has their head against the headrest, so the patient is nice and stable, because sometimes if they haven't got their heads against the headrest, they tend to jerk away from you or could move involuntarily. Mark? Explanation to the patient. Excellent. It's always a good idea to communicate with your patient and smile at them while you're at it. So explain what you're going to do, explain how it all works. Maybe, it's not going to take too long. Anything else?
Selecting the right exposure factors.
Absolutely. So before you actually take your radiograph, make sure that you've got the correct exposure time for the area that you are looking at. Anything else?
Holders? We said holders.
No, well, we use holders, so that's one of the reasons why you're here today, because we're going to be going through the holders. It's always a good idea to use holders, one, so that the image is going to be standardised, and that that actually the patient can bite onto it, and you have a beam aiming device so that you're aiming your X-ray beam exactly into the correct position. Always assume you've positioned your image receptor into the correct position. Also remember that the speed of your image receptor will also reduce the dose of the patient. So we should be using F-speed film, which you will come across at Southend. Image receptors like charge coupled devices are actually much quicker than the indirect digital, which is what we use here. F-speed film and indirect digital phosphor plates are probably about the same speed, but it all reduces the dose to the patient. We also need to remember that once you've got an image, whether it's on a film or the indirect image receptor, you have to process them. They need to be processed correctly. So they need to be processed the correct way around with image receptors, and we'll go through that in a minute. So we can avoid unnecessary repeats. And with film processing, all the processor, the chemicals, everything, which I know Carlene has gone into, they need to be the right temperature, they need to be the right concentration, so that we do not have to repeat our radiographs. Now, you two, any more? Have I covered everything?
Yes.
They're putting their thumbs up, but anyway, I'm sure there are loads more. But please make sure that we've just got to make sure that we reduce the dose of the patient. We've got LED screens to stand behind. It's the patient that we're most concerned with.
Okay, so Sarah just went through the 3 fundamental principles that governs EMA. She mentioned justification, limitation, and optimization. So basically, optimization is getting the best radiograph but using the lowest possible dose. Oftentimes optimization and limitation overlap, and Sarah has gone through how you can limit the dose to the patient. But to get the best quality radiograph, one of the things that comes to mind, or some of the things that you'd have to do, one is training. So basically we are training you guys so that you'd be able to get the best quality radiograph using the lowest dose. Also, Sarah went through preparation, and like I said, these things do overlap. So for you to get the best quality radiograph, it means that you have to prepare your patient adequately. You'd want to explain the procedure to them and tell them your expectation. Also, you'd have to position not just your patient, but the extra equipment. And Sarah mentioned that it has to be as close as possible, and she mentioned the inverse square law and the effect it would have if the X-ray tube is further away. You'd also have to select the right exposure to be able to get the best quality image. And remembering that the teeth have various densities, so the exposure that you'd use for your canine, for instance, would be completely different from what you'd use for your molars. Also, for you to ensure that you are getting consistently good radiographs each time, you'd have to do something we called, or carry something we called audits. So you have to carry out an audit, not just on the radiographs that you've taken, but also on the equipment that you're using, to make sure that consistently they are giving you what you require to produce the best quality images. Servicing. Well done, Sarah. So yeah, you have to make sure that the equipment are serviced regularly, making sure that they are giving you the optimum that you need. Is there anything else that would come under optimization?
Viewing conditions?
Yes, you're absolutely right. So your viewing conditions should be adequate. There's a guideline, and this was covered in the imaging processing lecture, that the viewing computer should satisfy certain requirements. So DICOM, it should have a high resolution, high contrast. So yes, your viewing facility should have these things and tick all the boxes. Are there anything else that needs to be
Processing,
covered?
Processing.
Good. So your processing equipment should also satisfy certain criteria. If it's film that you're processing, as Sarah said, you have to check that you're developing solution, your fixer, water, all these things are adequate and working at their optimum. Temperature should be adequate. Anything else, guys?
Continuing professional development.
So it's very important that you have a continuous check. So you continually check all the things that we've mentioned, i.e. your equipment, your image processing. All these things should be consistently checked, and this will come under audit. Are there anything, guys, that I might have forgotten?
Reporting, audits of reports.
Good. So you'd have to report your radiographs under very good viewing condition, and this room is not ideal because your room should be slightly dimmed for you to be able to work out if there's any or pathology or whatever you're looking at. For you to be able to get a good report, your viewing condition should be adequate.
Okay, so we talked a little bit about the X-ray tube and the various parts of the design of the tube that help protect the patient. So we have some shielding around the back, and as Sarah mentioned, we have the collimator on the front. And inside, you may remember there's the aluminium window. We'll talk about that in a minute. But what would be good to think about for a moment is what happens inside. How do we get X-rays out of it? Because when we're thinking about setting our exposures, it's important to remember what is going on in the tube. So when we're making the different settings, what effect does that have? Now, normally at this point, I would ask a student to take a pen and come up and draw a lovely picture of the X-ray tube on the wall here, and probably one time out of 10 they might actually manage to do it. So we usually do it by committee, so I'm hoping that my colleagues are going to help me remember what's in the X-ray tube. So can anyone remember what we have inside the X-ray tube here? Carlin.
Filament.
We have a filament, okay. So you may remember we have a filament, which is basically a piece of wire over here. Excellent. And what goes on with the filament? What happens there?
Well, it's made from tungsten.
It's made from tungsten. Now you may remember from your lecture that it's made from tungsten because tungsten is good at thermionic emission. It can Can anyone remember what thermionic emission is? What happens in thermionic emission?
Well, it probably gives out a lot of electrons for little power.
There we go. Model answer from Sarah. Thank you very much. So, those of you who may remember the old style light bulb, you basically had a filament in a light bulb and you passed a current through it and it glows. Why does it glow? Because you get lots of electrons coming out of the actual filament and they basically warm up the gas that's in the bulb, and there it is, it glows, and it's lovely, and we can see by it. Now, in an X-ray tube, you don't have a gas, but we do want electrons to come out of this filament. So we want a good thermionic emitter, which is tungsten. Excellent. So we've got a filament. What else do we have? Anything else?
A vacuum.
We have a vacuum. Fantastic. So I'm going to draw. Well, I'm not going to draw anything actually because this particular pen is just packed up. Thank you very much. So here's a nice glass tube there. So we're producing electrons within a vacuum. Now at the moment, all those electrons are going to do is this filament is going to warm up, the electrons will get excited, they'll emit for a fraction of a second from the filament, and then they'll lose their energy and they'll just drop back in and they'll keep going round and round the circuit, and if we left that on forever, the filament eventually would burn out. So that's not very exciting, is it? That's not going to give us X-rays. What else do we need?
The target.
A target.
In an anode.
In an anode. Aha. Now we have an anode. What's an anode?
Well, it's copper block.
We'll come back to that in a moment, Sarah, but what is an anode? And what else do you have to have if you have an anode? You've got to have a cathode, have you not?
Yes, so that's the filament.
Ah, so the filament forms the cathode, and the anode is over the other side. So we've got one which is going to be positively charged, that's why it's called the anode, and the other one is going to be negatively charged, that's why it's called the cathode. Now, as Sarah rightly said, the anode has a huge amount of copper in it, but it also has a target, which Carlin mentioned, which sits within there. Now, what happens with all this? Why do we have a target? What is that target going to do? So what we are going to try and do is to focus somehow these X-rays and bring them over here onto this target, and by accelerating them across and then rapidly decelerating there, that's how we get the X-ray production.
Mr. Viner, what's the target made from?
So, very good question. What is the target made from? And that is a very good question because X-ray tubes do differ from one type to another. This X-ray tube is designed for producing X-rays at energies that are good for looking at bone and soft tissue generally across the human body. So we want X-rays that are produced in the range of maybe 50 to 100 or so, being optimum around about 70 kV. So we would choose tungsten. We'll come back to the reason for tungsten in a minute, but tungsten has the chemical symbol W. If we were looking at soft tissue, and an example is breast tissue, we wouldn't be using tungsten, we'd be using molybdenum, because that's better at producing X-rays at a lower energy, around about 35 or so. But tungsten is particularly good around 70, so that's why we choose it. If you're looking at aircraft wings and things like that, you may use other materials, you may use copper. So it really does depend. But what has been designed for you is a nice little X-ray tube that Mr. Rodkin would remember, and it's got tungsten in it. Fantastic. How do we get our electrons from here over there?
KV.
KV, right. So we have two circuits here. We have a filament circuit, and that's the one that's warming up the filament, making the electrons come out and doing it into this cloud here. But then there's another circuit that connects these two across the top, and this, Sarah's just mentioned kV, and let's put 70 kV. What does that mean? 70,000 volts. If we put a current of 70,000 volts across there, what it does, it makes this side 70,000 volts positive, and this side 70,000 volts negative. So there's a huge difference in the two. And if you're a negatively charged electron, what are you going to do faced with this lovely big positive charge over here? You're going to go racing across. You're going racing across over here, and you will hit a big lump of immovable object. So what happens at that point?
Well, then you have interactions from the incoming electron with the electrons within your tungsten in your target. And that's one of the reasons why, of course, we use tungsten, because it's got a high atomic number.
Excellent. Okay, so going back to one of the fundamental laws of physics, you can't create or destroy energy. So we have given energy here because we've got a potential difference between the two. These little electrons accelerate across, gaining kinetic energy as they do, and they're suddenly decelerated, and that energy's got to go somewhere. So as Sarah said, you've got a number of interactions that happen within this lump of metal here. And what's the most significant transfer of energy that we get?
Heat.
Heat, yeah. So 99% of the energy that we gain going across that X-ray tube is developed as heat. And that is why this target is set within a copper block, because that's going to conduct the heat away. And the whole of this tube is in oil. So that sets up convection currents within the oil, and it takes the heat away. Because you don't want the tungsten target here to be affected by the heat.
But doesn't the oil also provide insulation?
It does, very good. So electrical insulation as well. Yeah.
It does.
But yeah, good point, Sarah. So it also gives protection as well to the operators. 'Cause remember, we've got 70,000 volts here. We don't want for that to break down. So we've got good insulator as well. Okay, so what happens with the other 1% here? Well, that's going to come out a tiny bit of light, but the rest of it is X-rays. And there are two main interactions that happen within the target that give us X-rays. Excellent. So, photoelectric and Compton effects. So, in terms of the production of X-rays within the tube, the photoelectric effect we often refer to as Bremsstrahlung, or braking radiation. And what's happening in this particular case is that a little electron here that's been accelerated across collides with the tungsten. And if you imagine the atoms of the tungsten here, you've got the nucleus of the atom there. And you've got the other electrons orbiting around there. Imagine that this incoming electron passes really close to this nucleus here, and as a result it loses energy, and as it loses energy, the energy that is lost is given off as an X-ray photon. Now, depending on how close it passes, depending on how much energy it loses, and therefore you have a number of collisions happening, and you will produce what we call a continuous spectrum of energies. So if we were to plot a graph of the photon energy on the bottom and the number of photons possessing that energy, we would get a spectrum here, which is going to be clustered around the voltage that we put across in the first place. So this is going to have a low number of low energy electrons, rising to a peak in the middle of around about what we've set, so photons that would have 70 kiloelectron volts, and then tailing off for the higher energies. And that we call the continuous spectrum. Now, in terms of the Compton effect, what's happening in the Compton effect is that the electron coming in collides with one of these other electrons in the outer shell of the atom. And in doing so, it ejects it, and an electron in the outer shell falls in to take its place. And as it does so, it produces another X-ray photon. And the energy that it does this at is dependent on the atomic number of the material. And it just so happens that we refer to the K and L shells, which is basically these rings, if you like, as you go further out. But the energy, the K shell energy of tungsten is 69.5 kiloelectron volts. So what that means is that at 70 kV, which is what we're setting, we get an extra peak here of a huge load of photons that are coming out with an energy of around about 70 kiloelectron volts. Now that, if you remember, is going to be really good for us because they're going to be able to penetrate the bone and the soft tissue and give us a nice exposure around about the areas we want. Now, one more thing to say, we're going back to the design of the tube, and I mentioned it briefly a few minutes ago. What we don't want is a lot of this low energy stuff here, because what that is going to do is it's just going to go into the patient's tissue. It doesn't possess enough energy to go right the way through, and it's just going to basically deposit that energy within the tissues and potentially give rise to effects that we don't want, can induce cancers, etc. So we want some way of getting rid of these low energies. So what we do, we put a filter within the X-ray tube. That little filter sits across here. We have a window, and we filter the radiation coming out so that only photons with sufficient energy to penetrate the patient, if you like, come out of here. And we use an aluminium filter for that purpose. Some X-ray tubes use copper, but we use an aluminium filter in this particular one.
And that reduces the dose to
And
the
that
patient.
reduces the dose to the patient. Thank you, sir. Okay, so let's just think a minute about the controls that we have within the X-ray tube. Now that we've refreshed our memories in terms of what's happening within the X-ray tube, and so file that away for future laters, we're getting to the important thing now, which is how do we control what is happening in the X-ray tube and what effect does that have on our image? So really we've got 4 controls. The first one is how hot is this filament getting? Because the hotter that gets, the more the more electrons will come out of it, and therefore the more photons will result in the X-ray tube. So by changing the current of this, we can affect the number of electrons that we get. I'll come back to that in a second. But that's known as the tube current, and it's measured in milliamps. Okay, so we talk about the MA of the tube. We say we can have 5 MA, 10 MA, 15 MA, whatever. We could adjust that. The other one is the kilovoltage, and that is going to really adjust the energy that the photons will have, because it's going to adjust, if you like, the speed that the poor little electrons are going to go across here and be decelerated in this great big lump. And so on X-ray sets we might have a setting between 50 and 100 or 110. By changing that we can change the energy that the resultant photons have, how penetrating they are. The third thing we can do is the time. How long do we have it all switched on for? Clearly, if I'm producing a set number of electrons over here, let's say 10 per second, and I'm calling for an exposure that needs 20, then I can either bump up my MA, so I produce more in the same amount of time, or I can run the tube for longer, so I can run it for 2 seconds and then get the same exposure. So I can use time. And the final thing that we have, and something that Sarah mentioned earlier on, is the distance. Remember the inverse square law, the closer I get, the less exposure I'm going to need, the further away, etc. Now we try and simplify things in dental radiography because we're taking X-rays of a pretty constant structure. Most X-ray tubes have intraoral X-ray tubes, have a set MA. Some of them are set at 10, some are set at 7, I think this is, some are set at 8, 9, but you'll find there will be a fixed MA. So you don't really need to worry about the MA. Most intraoral X-ray tubes will only have 2 settings for the kV, some of them only have 1, and that will be either 60 or 70 kV. As Sarah has already mentioned, we prefer to use 70 because it reduces the patient dose significantly.
Doesn't the IRMA regulations state that we should be using 70?
The IRMA regulations state that we should be using 70, as Sarah has rightly pointed out. Okay, so in a moment, Carlene is going to show us the X-ray tube, but the main thing that you're going to be changing, because you're going to stick with 70 kV, you've got a fixed MA tube, so for intraoral radiography, the main thing you're going to be adjusting is the time. And so Carlene is going to take us through how we change those factors on the modern X-ray tube. You will be using tubes like this, but you'll also be using older ones, which have got slightly different ways of setting them up, and we'll be talking through those with you as you come across them.
Okay, so behind me is the control panel, and the control panel you've got your kilovoltage, your milliampere, which is your current, and your time. This particular dental equipment is set at an MA of 7. And the reason why it's set at 7 is to prevent overheating of the filament to aid X-ray production. Also, the KV is set at 60 to 70. And Mark mentioned earlier that the X-ray photons that are needed to produce a diagnostically acceptable image are the characteristic X-rays. And these are set at a KEV of 60 to 70. The time also comes in play because you are dealing with bones with different density. So to produce a diagnostically acceptable image, you can't use the same exposure for the various density, the various areas that you have. The molars are denser than the premolars, etc., etc. So the duration of the X-ray will have to be shortened depending on the area that you are taking. Mark mentioned earlier about optimization, and we mentioned that optimization means getting the best radiograph but at lowest dose. So we have factored this in taking radiograph, and that's why we use 70 kV, because at 70 kV we get the high energy photons, which gives us a diagnostically acceptable image but at low dose. So now I'm going to discuss, show you features on the control panel. Okay, so this is the control panel. Like I mentioned, you've got your KV 60, 70, but then you'd want to keep it on 70 because that's the optimum you need to get a good image. The MA is set at 7, so this equipment is set at 7. You've also got different patient size. So if you've got an adult and a child, you will not be using the same exposure for an adult as a child. So if it's an adult, you have to click on an adult. If it's a child, you click on a child, and if you can see here, the exposure time decreases. Also, and I mentioned this earlier, that the bone densities are different. So if you're doing an incisor for the maxillary teeth, for instance, you click on that, the exposure time that is required to get a good image is 0.05 seconds. However, if you move to the molar upper left 6 or 7, for instance, it increases, and that's because the molars are denser than the incisors. Now let's see the effect of using 60 kV, and then you'd understand why we advise you to use 70 kV. So if you have it on 60 kV, can you see that the time has increased? It's ineffectively doubled. So what this means is that at 60 kV, this X-ray equipment is producing photons at both high and low energy frequency. And that means that the low energy will be deposited in the skin, increasing the dose to the patient. At 70, the photons have got high energy, so there's nothing that's deposited in the skin, so it reduces the dose to the patient. So please ensure that you are clicking on 70. And if you come into this room and it's not set on 70, please make sure that you click on 70. So this bit on the top is for the maxillary teeth, and the bottom is for the mandible or the mandibular teeth. If you're doing a bite wing, which obviously includes both the maxilla and the mandible, you click on the middle setting. So I'm going to take you through how to assemble intraoral holders. What I've got here is a posterior holder, and oftentimes the holders come pre-packed to keep them sterile. So before assembly, you have to open the packer, and that's your clean pad. So you assemble them and leave them there, cover them before you bring the patient. Okay, so there are two holders for periapicals. We've got the anterior holder and the posterior holder, and we've got another for bite wings, but this is in another video, but we'll recap it in this video as well. So I think we showed you this in the lecture. Can you remember what we call this particular holder? I'll give you a few minutes, pause your video and try and think about it. Yes, you're right. So this is a posterior holder, and for posterior holder means that you're going to take areas 4 to 8, okay, posteriorly, upper and lower. So I'm going to show you how to assemble the posterior holder. Oftentimes they'll come packaged like that, but I'd advise that you disassemble everything. Okay? Let's say you want to take a PA or a periapical of the lower right 6. Good. So for a lower right 6, you'd want to hold the bite piece down because you're taking a lower teeth. And what you do is you place the metal rod on the right hand side. Okay, so this is the right hand side of the metal of the bite piece, and then you assemble this circle such that you can see the phosphor plate or the film if you have it then. And when we went through errors and artifacts, you remember that when we assemble it the wrong way, we won't get anything. So this is not what you want to do. You want to make sure that this ring is focused on where the receptor would be. Okay, so I'm going to assemble it right again. And this is what you'd want the setup to look like. So this would be for the lower right 6. So it will be for the patient's right. So remember that when you're taking whichever quadrant, this curve should stick out of the mouth. So this assemble cannot be used for the left hand side because this will be in the way of the cheek. Okay? Okay, so the first setup was for the lower right 6. Now let's set up for the lower left 6. Okay? So same as before, you'd hold the bite piece or the bite block down like that. And which side will be the left side? It will be this side because that's my left hand. Okay, so you place the metal bit on the left side like that, and then you put this part of the beam aiming device through so that you can see the receptor in the middle, nicely centered. Okay, so this is what the setup will look like. All right, so this is for the lower left 6. Okay, so for an upper, you then have to hold the bite block up. This is for lower, this is for an upper. So let's say we're doing an upper right 6. So hold the bite block up, that's my right hand. Place this on the right side of the bite block, and then assemble the circular bit so that you can see your receptor through. And this would be for the right side. So that's my right side. So this is set up for the right side. It won't work for the left because the metal bit will be in the way.
Okay, thank you, Carlin. So I'm now just going to take you through setting up the holder for the anterior periapicals. So the posterior one is coloured yellow, and the anterior one is coloured blue. And this is in the RIN system, RIN holders. You'll find that a lot of other manufacturers have adopted those colours, but some have gone slightly different shades. But these are the ones that we're going to be using throughout your 5 years here, and they also use them at the other sites that you'll go to, for example, Southend and the Barclaycard Centre. So the anterior holder is designed very slightly different from the posterior. You can see the posterior one there, it holds the film in a landscape position, whereas the anterior holder is going to hold the film in a portrait position. And the reason for that, if you think about it, as the teeth come forward around the arch, they get longer and thinner, and so it's much more difficult to actually place the holder in with the film in the landscape. That's going to bend, whereas if you place it in the vertical position, it's going to give you a nice image of the entire tooth from crown to apex. The other thing that is different is that the little bar it comes away and down from the holder, whereas for the posterior one it comes out to the side. And again, if you think about this, if you put that in the mouth, that comes out towards the front, as Carlin was saying, whereas this one, when you place this one into the mouth, and we'll show you this in the dummy in a minute, that's going to come down and away. Okay, so exactly the same procedure. When you open the packet, as Carlin showed you earlier, make sure that you separate all of these pieces. They will sometimes come together, put together, but you can't assume that people in CSSD have done it correctly. So, first thing again, think to yourself, am I doing an upper or lower? Take out the holder here and look at it face it upwards, all low. Doesn't matter with this one, but the key thing is that when you place the bar in, it should be coming down and away from the holder like that. You don't want to put it in on this side, up there, because it's going to get in the way of the x-rays. So with this one, it doesn't matter whether you're doing an upper or lower, left or right, it always sets up exactly the same way. And this holder always goes on that side, the right side of the holder there, and comes down and away like that. Okay, so you remember on the, when we look at the posterior, it was quite important to get the ring around the right way. And that's because, if you can see here, the little bracket at the bottom is offset to one side. So we have to think then whether we're doing an upper or lower and put it on so that we can see the bite guide right in the middle. With the anterior one, you can see that the bar comes straight out of the bottom. So actually it doesn't matter whether I put it on that way or that way, it's still going to be right in the centre. Clearly, what you don't want to do is to put it that way because that's completely wrong. So just get that nicely set up, and that's how you set up your anterior holder. Okay, so the other holder I'm going to show you is the bite wing holder. So you remember that the posterior holder was yellow, the anterior periapical holder was blue, and the bite wing holder is red. Now, just one thing to point out, which I forgot to mention before, that these bars that we use as part of the beam aim device, they've got little colour codes at the end of them. So that one, you can probably just see that is blue at the end, so that's an anterior one. This one is red, so that's going to be the bite wing one, and the posterior one has yellow prongs on it. So if you get them confused, you should be able to identify them fairly easily. Okay, so again we have three parts to this holder. We have the bite guide there that's going to hold the film. We have the bar forming the beam aim device with the ring. Now then, when we place these into the mouth, these are very, very slightly different because the film is going to be held in these grooves here. So if you look at the posterior holder, it just literally has one slot into which we're going to place our film. So here's an example there, the film there, up there, like that, will sit in. But for the bite wing holder, we're going to have to slot both sides in like that, so it's two-sided like that. The other thing to think about is that when we place this into the mouth, obviously it's got to sit on the lingual side of the teeth, and the teeth are going to bite down like that. So the holder needs to be coming out that way, there. Okay, let's just look at the bite guides here at the end, because they grip at the top and the bottom, we have to have different size ones for adult and children. Because the adults we're going to use a size 2 film, which is this one, and children we're going to use a size 0 film. So we would need a slightly different guide which has slots here which are smaller, which allows us to get the small films in. So when you get the package out of the cupboard and before you open it, have a little look on it. See first of all what does the label say? Does it say adult or paediatric? And the other thing, because you can't always rely on the label, I have found, is to have a look through the plastic and just make sure that you've got the right size one before you open it up. Okay, so now we're just going to set this one up. We're going to set the adult one up. Dead easy, we do this exactly the same way, whether it's left or right. And of course, because it's a bite wing, you don't need to think about upper or lower, because we're looking at the crowns of both teeth. So we simply hold the holder like this, looking at it with the film facing away from us there. We take the guide and place it in that way, so it's come towards us. And once more, we put the ring on there so that we can see that straight through the middle. And again, this ring is exactly like the blue one. The bar comes out from the bottom there, so there's only one way to put it on. Okay. So that is how we set up a bite wing, adult bite wing. Now the other one thing to mention, a very rare occurrence, but sometimes we have to do a vertical bite wing. And what that means is that instead of holding the film in the mouth horizontally like that, we're going to hold it in vertically. And quite often we would need to do that if there's a high degree of bone loss, so that because we want to see the bone level. And in those circumstances, we're going to use a vertical bite wing holder. And what that does is going to hold the film in vertically. And I've got one for a size 0 here, but you can see that it's just very, very slightly different. And again, when you open up your packet, setting up for a bite wing, just make sure that you've got the correct one. The one that you're going to be using most of the time is the horizontal bite wing, and you'll be using them for both adults and children, so make sure you've got the right size and it is going in the horizontal direction. Okay, so in a moment we're going to take you through how to position these on the patient. We're going to do that on the mannequin, so we'll just take you through exactly how to use those in practice. Okay, one more thing before we move to actually showing you how to take the periapicals and the bite wings. We need to think about the recording mechanism that we're going to use to actually record the image. And so we're going to be using these phosphoplates. Now remember we talked about these in the lectures at the beginning of term. So this is a size 2 phosphoplate, this is a size 0 phosphoplate, and this is a size 4 phosphoplate. Now these ones are very handily numbered on the back. You can probably see that says 2. And so if you're in any doubt, just look at the back of the plate. The other thing the back of the plate will tell you is that it is the back. And on there is the little word back, and that's really, really important because the phosphor is on that side, as you can see, and that is light sensitive. Now we don't have to worry about it before we take the X-ray because all the white light will do is just clear any image that's on there. But once we have placed it in the patient's mouth and exposed it to radiation, it will have that latent image on there. What we don't want to do is to expose it to light at that point before we processed it, otherwise our image gets wiped out. So what we're going to do is we're going to use one of these little saliva barriers, but it's also opaque on one side. And this one happens to be black on that side and clear on the other. And what we need to make sure that we do is to place the plate into this packet like that, so that the phosphor is covered up by the opaque side. Okay. Now people get very confused about these because some of them have a white side there, some have a black side, and some have clear and some don't. The most important thing is for you to know, firstly, that you have to cover up that to protect it from light. It doesn't matter what colour it is, it could be pink, purple, doesn't matter. And the other thing you need to know is which is the back. So if you've got one that's white on the front and black on the back, i.e. opaque both sides, you need to remember which side is the back of the plate. So once you've popped it in, you seal that up and that's nicely kept in there. It'll protect it from saliva or protect it from physical damage and scratches, and it also protects it from light. And we'll show you, once we've taken the X-ray, how we process that without light reaching the film. Okay, now one more thing, and I'm just going to reiterate, we did mention this in the lectures as well, is that the phosphoplates have a copper dot on the back of them, great big copper dot there. And you'll remember that that is to tell us, if we inadvertently place this in the mouth all the way around, the radiation will go through the plastic there. Some of it will be absorbed by that copper dot, and we'll see a big round circle on the image. And what that tells us is that the plate has been put in the mouth all the way around. And so when we're looking at that image, it's going to be a reversed image. It's going to be flipped, so that the left side will look like the right, or vice versa. And what we need to do is either to repeat the image, or electronically to flip it, but if we do so, we need to record that so that anyone else looking at that film knows it's the right-hand side and not the left. That's a really, really important thing for you to remember, because we have had incidences, not just here but in other hospitals, where the wrong tooth has been identified and in some cases extracted on the basis of an X-ray that's been flipped all around. So really, really important, remember to place this in the right way in the mouth. If you see that big copper dot, you have placed it in the wrong way around. Okay, so now we're going to go and look at how we actually use those phosphoplates on Dexter. Carly.
Okay, so this is Dexter. We're going to take a posterior periapical on Dexter. I've already got my holder set up. So now I want you to pause the video and think about it for a second. What is this setup for? Is it for the upper left or upper right? So think about it. So I think you all got it. It's set up for the upper left. So we're going to take the upper left 6 of Dexter. And as Mark mentioned, we've already pre-assembled our phosphor plate. The back is towards the clear side and the phosphor layer is covered because it would be sensitive to light once the x-ray has been taken. So we want to place the phosphor plate in the slot, making sure that you can see the phosphor plate through the ring. Okay, so that is Dexter, and remember that you have to go through all your preparation, and we mentioned this in the lecture. So you'd want to ask the name, date of birth, you'd want to confirm the sites that you're going to take the x-ray of, ask Dexter if they've got any removable prosthesis from the mouth, i.e. dentures or tongue piercing or anything of that sort. Also, you'd want to let the patient know that it's going to be a bit uncomfortable. Oftentimes, patients want to know whether it's going to be painful or it's going to dig in or whatever. What you want to assure them is that it's a little uncomfortable, but it's going to be for a short time. Make sure that before Dexter, you get the patient in, you've set your parameters. So for the lower, upper left 6, I'm going to set the parameters. So I've got Dexter as an adult, so I've set this for an adult. Upper left 6 premolar, molar, sorry. So I've got it there, and it's on 70 kV, so I'm ready to go. Okay, good. So at this point, I'm going to get Dexter to open the mouth really wide, and that's what you want to get the patient to do. Okay, and then I'll place the whole assemble in the mouth, making sure that the phosphor plate is parallel to the long axis of the teeth, as you can see here. Once I have it in position, I get the patient to bite down gently and then secure this in. Okay? Tell the patient not to move, keep absolutely still. We want to bring this device as close to the cheek as possible to prevent divergent magnification of the image that's produced. And also from the lecture, you remember we said that you assemble your X-ray tube so that the horizontal and the vertical angulation are correct. You want to bring this X-ray tube perpendicular or at 90 degrees to the receptor in the tube. And this is what I'm going to do now. So if you look at it, you can see this line is parallel to the metal. Okay. Yes, so it's not, so I'm just going to adjust it a little bit. And look at it, yes. So now that looks parallel. I'm going to check here as well, making sure that everything is aligned. So this is your vertical angulation, and so you want to make sure that, as I mentioned earlier, it's perpendicular. If it's not, then you're going to get elongation or foreshortening. So you want to make sure that it's coming in perpendicular. And I'm going to check it again, it's not properly aligned. Yes, now that is aligned. So we're going to show you what to do with the horizontal angulation to make sure that's also aligned. Okay, so for your horizontal angulation, you want to make sure that this line here is parallel to this metal rod. And as you can see, that this is parallel. So it means that your horizontal angulation is adequate. If it's not, as you can see here, it's slightly tilted. So this isn't. So if you take the X-ray with this sort of positioning, what you're going to get is a lot of overlapping of the crowns of the teeth. So you'd want to make sure that it's parallel. Also, if you look at the end of the collimator, it has some notches on there, and you can see that on the ring as well. The ring has notches. So to make sure that your horizontal angulation is perfectly aligned, once you get these lines parallel, you want to turn the notches so that they are nicely aligned as well. So it isn't just these lines parallel, but the notches would have to align with the notches on the ring holder as well. So once you've positioned, you tell the patient to keep absolutely still, go behind the screen and press your exposure button. But you need to remember that you don't want to spend the whole time positioning this, because think about it, you've got a holder in the patient's mouth. It's a bit uncomfortable, as you've explained to the patient. So you want to do it as quickly as possible, but try and make sure that everything is aligned, and then press the exposure button at the back.
Okay, so having taken the exposure, we just need to take the holder out of the patient's mouth. So come around. When you're taking the tube away, just be very, very careful to move it back and away. Don't knock this. The last thing you want to do is to knock that and jar against the patient, and they won't be very happy. And then we ask the patient to open their mouth, very gently take the holder out. Oh, now then. What's happened there? The film has dropped off. Now that sometimes happens, and that's why you need to be really, really careful when you put these films in to make sure that they're nice and tight in the holder. What you find over time is that because these get autoclaved, the plastic gets a little bit worn, and particularly these very, very thin fossil plates have a tendency to move around. So it's a good idea sometimes, if you can, just to put something else in there with them. I quite like using the little bite tabs, which you can get, little bits of cardboard that's specifically made for using for bite wings actually, but I pop them in there to hold them nice and tight. I know Sarah uses a little bit of paper, sterile paper from the packet. People use a variety of things, but the main thing is make sure that doesn't move around. Otherwise, sometimes you can see it drops off. Okay, so that was the posterior periapical. I'm just very quickly now going to take you through doing an anterior periapical. And what we're going to do is to do the upper right 3, so again an upper tooth. So you'll remember that we're going to use the anterior holder, which is the blue one. We're going to use a size 0. We're going to place it invertically because of the narrow arch here at the front. And we're going to pop that in, ask the patient to open the mouth. I'm going to pop it in up there and ask them to bite down. Now, one important thing to remember is that what we're doing is we're placing this holder into the mouth where we want it to be, and we're asking the patient to bite down, to hold it where we've put it. Now, I see no end of people just popping these into the mouth there, holding it around, somewhere around roughly the right area, and then asking the patient to bite, as if the patient knows where it's going to go. So the important thing to do is to place that bite guide against the tooth we're going to x-ray. So against the crown there. And you can also, when you do that, you can feel whether it's touching the roof of the mouth. Because if it is, it's going to bend. So you may have to just off-centre it slightly. Having got that into position there, then you ask the patient to bite down onto it. Now, I don't know whether you can see what's happening there, but as the patient bites down, this whole holder is tilting away to the right. And that's because he's got some broken teeth here on the bottom. And when he bites down there, it's not biting straight. Now that's not just a problem we have with Dexter, we have problems with all sorts of patients who've got different pathology in the mouth. So sometimes it's a good idea to get something to place underneath, and we use a cotton wool roll. So just going to ask Carly if she could pass me a cotton wool roll, and I'll show you how we're going to use that. Okay, so thank you, Carlin, for that cotton wool roll there. So we're going to have another go at positioning this in the mouth. And again, we'll ask Dexter to open wide. Place the holder up against the crown there. And I'm going to place this cotton wool roll just underneath there, just across the arch there of the lower jaw. And just ask the patient to bite. Just compress that cotton wool roll, and you can see that's now holding it much straighter. If we don't do that, if we don't have it straight, what happens is the film will tilt to one side, and because it's narrow and thin, and we've got it in the vertical orientation, which we have to in the front of the mouth there, we risk missing the apex of the tooth off the image. So always try and make sure that your film is nicely lined up along the long axis of the tooth. And so again, we're following exactly the same principles that Carlin showed you a couple of minutes ago when we did the posterior teeth. We're just going to line the X-ray machine up, using those lines on the side. So I'm now looking at my vertical angulation here, making sure that that's nice and lined up there. That's looking good. And having done it from the side here, I need to now come round the back of the tube here. I have to stand in line with it and see then whether it's lined up in the horizontal angulation. And this, it isn't, so I need to move it round this way. Now I can see that's beautifully lined up. And the very last thing I do, again, exactly as Colin showed us, is to just tilt that so that little notch is lined up. Okay, so just to repeat that, you can't do everything from one side. You're trying to line something up in 3 dimensions and you're using 2 lines at right angles to do that. So you have to look at right angles to that line and come round here and look at right angles to the other. That will enable you to get it perfectly lined up and give you a really good radiograph.
Okay, thank you, Mark. So I'm going to demonstrate how to take a bite wing radiograph. This is the bite wing holder as Mark showed you earlier. So for bite wings, for an adult, you'd want to aim at getting 4 to distal 7. So mesial 4 to distal aspect of the 7. For pediatric bite wing, you'd want to get C, D, and possibly E. If they are a bit older, you want to get the 6s in as well. So Dexter is an adult patient. I'd want to make sure that the setting is right, so I have it on the adult patient setting. I'd also want to make sure that I have selected the bite wing setting as well. So that's the middle bit. So that's the icon in the middle. So I've clicked on that. So you go through all your preparation as well, name, date of birth, if they've got anything removable in the mouth. So as Mark said, for the bite wing, it doesn't really matter. The same setup can be used for both the left and right. So I'm going to take since I'm standing on the left, I'm going to take the left bite wing. So I ask Dexter to open really wide. And then I place this in the sulcus parallel to the long axis of the teeth. So same positioning as you would for anterior and posterior teeth. But then remember that the edge of the phosphor should be sort of middle of the 3 to guarantee that you get the premolars in. So I don't want to push it too far back, otherwise I'll miss the premolars, or neither do I want it too far forwards because I wouldn't get it parallel to the long axis. So there, about 3 region, get the patient to gently back down. Secure it in and then push it in. As Mark said, if you find that the patient has got no teeth in the region that you're taking, such that the holder is not able to lie parallel, you can support it with cotton wool roll, as he did with the anterior teeth. So I'm going to line it up again. So with the lining up of the of this particular one, it's same as you would do for posterior teeth. So you bring it in, making sure that this line is parallel to that. Okay, so that's your vertical angulation. It's still not right, so keep checking so you have it nicely aligned. Okay, and then check your horizontal as well, making sure this is aligned, and then the notches, turning the collimator so that the notches are nicely aligned. So once you've positioned the go behind the screen, press your exposure button, and then you can release it. Okay, so the patient is nicely positioned. I've come round the control panel. I'm standing behind the screen, so I'm ready to press the exposure button. But first, I want to check that the patient is still in position. The patient hasn't moved. I press the exposure button, and you hear that beep, and then I go behind and take the Okay, so I have just taken the holder from Dexter's mouth. Just bear in mind that this is definitely filled with saliva. So what you want to do is, once you've taken it out of the holder, you give it a nice wipe, or a nice clean with the universal wipe, and then dry it out. Okay? Okay, so it's sort of clean now. This is our processing equipment, and Mark showed you this during the lecture. So this is for the indirect digital. So I'm going to process this phosphor plate. There's an indentation here and I rip that bit, okay? But you'd want to make sure that you don't expose this to light. The laser light is away from you, so you'd want to feed the phosphor plate in this way, not the other way, okay? So this way, and then what you do is gently push the phosphor plates down the processing equipment, holding on to that packet. Okay, you don't want to feed it with a packet because it won't scan the image if you've got the rubber going in with it. So hold on to the packet and gently push your phosphor plate in. It will read the image and then wipe the phosphor plate and come out clean at this tray here. Okay, once it's ready, it would open up and then I can take this and drop that in the clinical waste, okay? Okay, so I don't know if you saw a preview image, but there was a preview image coming on the screen. Just to remind you that if you don't see any preview image, it could possibly mean that you have scanned your phosphor plate the wrong way around. So once it comes out, quickly grab it so that you don't expose it to light and then refeed that into the processing machine. Okay, so this is our viewing area. You can clearly see that I have taken my gloves off. I've washed my hand because this is your clean zone. So you don't want to bring any dirty gloves in here. So this is what the image looks like. The image that was scanned. This is how it would appear on the reading machine. So I have to think, what side have I taken? Have I taken the left side or the right side of the patient? The bite wing that we just took was the left bite wing, so I need to orient this properly. So we've got various icons on here, so you can turn it around appropriately. So this is how it should look. So this is the left bite wing, and that's your 5, 6, 7, 8. Okay. Now let's talk about the image. I mentioned earlier that for bite wing you'd want the mesial 4, distal 7. So looking at this image, it's slightly too far back position. Ideally you'd want to have the mesial aspect of the 4 in there as well. There are occasions that you would need to repeat this. If the clinical indication requires that you include the 4, the premolar ring, then you would need to take it. But if it's for generalized bone loss or bone levels, then this would do, but it would be a grade 2 because it doesn't have everything that you need on it. What you also want to check is the exposure. Are you able to visualize enamel, dentine, and pulp? Clearly you can see that here, so that's really good. Does this image suggest that the patient has moved? No, because it's not blurry, it's nicely in focus. So this is a very good image. Okay, so when you get your image, we want to grade it against the NRPB grading as to whether it's a grade 1. A grade 1 is an excellent image without any preparation, positioning, exposure, or processing error. A grade 2 is one that has got few errors but is still diagnostically acceptable. And a grade 3 is one that you can't use for any sort of diagnosis, so you'd have to repeat. So looking at this image, we're going to grade it using the NRPB grading. So looking at it, would you say there's any preparation error? So preparation error, have they got any dentures? Have they got any tongue piercing? Is there any movement suggesting that you didn't prepare your patient adequately? No. Let's now talk about positioning. So for positioning, like I said, you'd have to position your patient and then you have to position your image receptor in the mouth as well as your collimator. I mentioned earlier that for bite wing you'd want the mesial 4 to distal 7. So in terms of positioning, I haven't positioned it adequately because I don't have the premolar ring, it's too far back position. So there's an element of error. So I've ticked my box with an X because it's not ticked. In terms of exposure, what you'd want to ideally see is the different tissue structures, so enamel, dentin and pulp. Are you able to visualize them appropriately? So in this radiograph, you can actually see enamel, dentin and pulp nicely there. You can see the trabecular pattern, everything is in focus. So it shows that you selected the right exposure. In terms of processing, what are some of the processing errors that you might come up with? If I'd exposed this to light, as Mark discussed in the lecture, some aspect of it would be white, so you'd see the difference in contrast. Also, if I haven't scanned it well and the laser light will make some sort of streaking on there, but we don't have any of this sort. So preparation is fine, there's a bit of error under positioning, processing is fine, and exposure is fine. So what grade do you think we can give to this? And this is where I want you to pause the video and think about it. Would you give it a 1, 2 or 3? Well done. So the answer is grade 2 and the error is positional error.
Okay, so hopefully that's given you a bit of a recap on how to set up the holders, how to position the holders in Dexter's mouth anyway, hopefully, just like doing it on the patient, and how to assess your radiograph. So in the session that we would normally do face-to-face with you like this, we would get each of you to try taking a radiograph so you get a bit of hands-on. So we're going to be doing that with you when you come to radiology next term, and you'll certainly get a chance to take some radiographs on Dexter, and depending on the coronavirus rules and things at the time, we would also get you to position the holders on each other, so you get to feel what it's like to be a patient, and you can feel how those holders feel within the mouth, so that you appreciate why you need to be quick, and how to best position them so that it causes minimum discomfort. So we're all looking forward to seeing you. As Carlene has said, there's a lot of information in this video, so do go back through it again. Perhaps you may want to view it before your first practical session, just to give you a bit of revision before you come, because we'll certainly be quizzing you on it, so we look forward to that. Okay, thank you very much.